Welcome to the CAA 2021 webinar series. Today's webinar is Connecting Clinicians and Data to Influence Patient Outcomes, proudly supported by Trapeze. Today's presenters are Mark Ainsworth-Smith from the NHS, Sam Allender from Ambulance Tasmania, and James Wetherall from the Trapeze Group. Thanks for joining us and please enjoy.
Hi, my name is David Waters and I'm the Chief Executive of the Council of Ambulance Authorities. Welcome to the latest in our webinar series. Today's webinar is looking at connecting clinicians and data to support patient outcomes. This webinar is proudly supported and sponsored by Trapeze. I hope you enjoy it. Thank you for attending. We have a full agenda for you today. Our first speaker is Mark Ainsworth-Smith from South Central Ambulance in the UK. South Central Ambulance Service in the UK will showcase how they have leveraged data and analytics to successfully change their model of care and ultimately deliver 30% more jobs with no additional resource increase. Following Mark, we will go to Sam Allender from Ambulance Tasmania. Sam's going to talk about the connected patient and how Ambulance Tasmania provides patients with alternative treatment pathways through secondary triage and coordination with third-party providers like private hospitals. And finally, to round off our speakers for today, we will hear from James Wetherall, Managing Director from Trapeze Group. James will talk to us about interactive digital twins, how technology delivers rich, real-time, interactive digital representation of pre-hospital patient care information, and see how the next generation approach is providing new opportunities for collaboration and post-care research. Following our four presentations today, we will have a live Q&A session, so please stay online and join us. Prepare your questions, pop them in the chat, and we will get the panel to respond to you. Our first speaker today is Mark Ainsworth-Smith. Mark comes to us with 33 years of frontline NHS experience. Mark has a particular interest in major trauma, sepsis, deteriorating patients, adverse clinical incident investigation, human factors, and GP education. Mark was awarded an MBE in the 2019 New Year's Honours List for services to emergency care and to major trauma. Welcome, Mark.
Hello everyone, my name's Mark Ainsworth-Smith and I'm the Consultant Pre-Hospital Care Practitioner for South Central Ambulance Service, often known as SCAS. I'm going to tell you about our experience using electronic patient records. Just a brief overview. SCAS is one of 14 different ambulance services across the UK. As you can see, we're right on the southern tip of the UK. And we basically all have the same response targets no matter which ambulance service we work for. Cardiac arrest, for example, there's a target time of 7 minutes. We've got very similar clinical care in terms of the standards of care that we deliver, but we have to evidence that using what we call ACQI, so that's ambulance care quality indicators. And there'll always be a degree of some local commissioning. So, for example, strokes in rural areas are much more difficult than perhaps in some of the urban areas that we cover. We operate in quite a complex setting. Our general population is about 4 million. During the day that swells because of commuters up to about something like 5.5 million. We cover a large patch ranging from the most rural type of areas in Hampshire and Oxfordshire and some parts of Buckinghamshire, all the way to inner city areas such as Portsmouth, Southampton, Oxford, Reading, etc. Until 2015, SCAS used paper records. The process was fairly complicated. The ambulance crews would complete paperwork. The patient would be given a copy, usually the carbonated copy underneath. The master copy would be scanned, and data analysis totally relied on humans. Indeed, we had our own team who had to scan all these forms and basically then review the information and type it into a database. Clearly, that was fairly inefficient. So we then made a decision to introduce electronic patient records. So the rollout, well, we basically had intense training for all of our staff, which included a sort of staggered rollout. We decided not to go live across the whole patch. We had electronic patient record champions who basically took real devices back to their ambulance stations and showed people exactly how it works. And we had test devices so that staff could play with them literally on station and get a good handle on how to operate them. But by 2016, in November, we were equipped with EPR on every single one of our SCAS resources. In terms of connectivity, our EPR devices were configured to connect to our monitoring devices. This meant that, for example, physiological readings, end-tidal CO2s, blood pressures, heart rates, ECGs, etc., are transferred wirelessly from our Zoll X1 device, the monitoring device we use here in SCAS, onto our electronic patient records. That clearly saves a good amount of time, and actually the accuracy, the information recorded, it's exact, because obviously blood pressures, etc., are transported across without the need for a human to intervene in that process. Electronic patient records allow real-time transfer of information. First of all, we can send information from the scene. So, for example, if we go to a serious road accident, we can take a picture of the scene and we can send that straight through to the emergency department. As soon as we select the receiving hospital, then that hospital is able to view the data. We can send information through to specialist centres. So we have hyperacute stroke units and PPCI, where we manage our, for example, heart attack cases and ACS. Now, what this allows us to do is to send the ECG through, for example, for a heart attack victim, straight through to the receiving hospital, so they can be planning on the care before we've even arrived. It also allows us to transfer information to GPs and healthcare professionals. So every single day there's a push through to every GP surgery, and what that means is that the GPs can view information, particularly for patients who haven't been conveyed to hospital, but also those who have, and it allows them to get a much better understanding of their patient's condition. And in SCAS, we have a clinical support desk. This is manned by both nurses and paramedics. And basically what they do is they give expert clinical advice to our staff out on the road. They're obviously able to view information real time, which is an incredibly important facet of that desk. It also allows crews to view important information. So if, for example, we've got an end-of-life patient who's got a DNA CPR, do not attempt cardiopulmonary resuscitation, or if we've had previous attendances, then crews can view that. And many patients have a summary care record, which basically means that we can see how they're normally managed. That might be, for example, a patient with mental health or COPD, but we can look at the management plan, which obviously means that the patient gets a much better deal. Before, we were totally unsighted on that, and often it was whether we'd been out to that patient before as to whether we knew what was wrong with them. And there's no doubt at all that having that sort of information can reduce unnecessary admissions to hospital, and certainly we're much better informed than we ever were prior to 2016. So has the introduction of EPR been seamless? Well, I have to be completely honest, there were some teething issues. These mainly related to increased on-scene times. So our on-scene times definitely increased initially when we introduced electronic patient records. That's because crews weren't completely familiar with the process and how it worked, and they were quite used to paper. There was frustration for older staff, particularly those that had grown up with paper, so they found it much more difficult to put everything onto electronic patient records, and that did create some frustration. And I'll be the first one to admit that I was one of those. I've now worked for the NHS for 34 years in October, and I found it really quite difficult using electronic patient records initially. We even found that some staff wanted to revert to paper because it was easier. There is something about paper, but actually in the long run, I think we found generally that electronic patient records are much more thorough and actually fairly simple to complete. We did introduce some simple measures to address this. The first thing I have to say is the introduction of keyboards. A lot of staff went out and bought their own keyboards, particularly with Bluetooth adapters. This meant that they could type notes much, much faster than using a tap screen. There was a lot around familiarisation and peer working. We found that the youngsters, particularly those who are recently out of university, were really quick at picking up electronic patient records. So working with older staff, without question, improved the process. And we had ongoing training from our champions. So at each ambulance station, there was a champion. In some cases, there were more than one. And they basically would talk about all the shortcuts and how you could perhaps work around things to create a perfect solution. In terms of data, data is stored in our secure data warehouse, and information can be used for many, many purposes. South Central Ambulance Service is very advanced in terms of research. We've done some great trials recently, including Paramedic 2, and this allows obviously us to retrieve data much faster than relying on humans to pull down all the data for us. It also mentions, or we also talk about audit. I've mentioned about ACQIs, Ambulance Care Quality Indicators. Each ambulance service has a set of standards that they have to meet. For example, for a patient having a heart attack, they have to document pain scores, and they have to document, for example, that clopidogrel is given or aspirin, or that we've given pain relief. And every ambulance service across the whole UK is actually measured on those ACQIs. So actually having electronic records has allowed us to complete those templates much easier than we ever would have had to do when we were on paper. It's also helped with planning, and I'll talk about some of the advantages, particularly, for example, with COVID. But with planning, we kind of know the areas where we're going to be busy. If we use this information intelligently, then actually we can plan where to put our resources, and we can plan when we need our resources. And the key thing here is that the information on our electronic patient records is good because it's inputted by clinicians. Historically, we've always taken information from the CAD, which is where our 999 calls come in. And as everyone will be aware, although patients generally give us a rough idea of what's wrong with them, often we really don't get very much decent information at all. And in this case, what this allows us to do is to get incredibly accurate information from clinicians who basically input the data onto our electronic patient records. So this is an example of some of the output that we get. This is a map looking at, as you can see, the South Central Ambulance Service patch down to the south coast there. This maps every single road traffic collision that we have had within a 1 year sort of window. And you can see there are some hotspots there, particularly in the south of the patch around the sort of Southampton area. We've got this line going north. That's what's known as the A34, which is one of our really busy routes where a lot of heavy goods lorries sort of make their way back up north up the country, and you can see that we can really accurately measure that. Now that can be very useful for resourcing, for example with our air ambulance teams, our critical care teams, etc. We can even break it down further. So this is a map looking at road traffic collisions involving motorcycles, and as you can see, we're getting some sterling data. That big blob there that you will all be able to see, you basically get when there's one incident, you get one blob, and the bigger the blob, the more incidents you've had. And unfortunately, that is one of the absolute hotspots here in the UK. That's where motorcyclists tend to meet. There's a cafe there called Lumi's Cafe where all the bikers meet, and unfortunately, we've had a large number of fatalities around that area. And then we can look at the days of the week and also the times of day when we're most likely to see road traffic collisions. No great surprises. We often see an increase in road traffic collisions, particularly when there is commuters on the road. So as you can see, that period between sort of 7 and 9 and then 4 and 6 is when we see real peaks in activity relating to road traffic collisions. And we can also look at days of the week. And very interestingly, what we have identified is that Friday, particularly Friday afternoon, is actually one of our worst days for road traffic collisions. And the severity scores, which we've also mapped with hospitals, are much higher. So we know that potentially people are much more unwell on a Friday when they're involved in a road traffic collision. And again, that can be factored into the resourcing that we have. This is an interesting piece of work looking at falls. So this is where a patient's fallen less than 2 meters. And we need to remember that although that sounds a trivial injury, that 40.1% of all major trauma going into our major trauma centre at Southampton relates to a patient who's had a fall of less than 2 meters. So again, you can see the benefits here. We've mapped where the road traffic, where the falls are happening, and you can see very clearly that we've got some really big pockets there where perhaps you might want to think about prevention teams or even having a full service run by the ambulance service. This is a piece of work that we did around stabbing. Cutting edge data from the ambulance service, I called the presentation. Unfortunately, I don't want to put anyone off coming to the UK because actually it's an amazingly safe place compared to some countries, but we do see quite a significant number of stabbings within our organisation, and you can see the pockets there of where we've got it. They're mainly urban areas, although a stabbing can actually happen anywhere. If we break it down, this is Reading, which is in the centre of our patch. You can see that there are some big hotspots where we've seen stabbings, and you can see that there's a general sort of conglomeration of them around the city centre there. And we can even break it down further. So we've gone to Portsmouth here. Portsmouth's a lovely city, but it does have its fair share, particularly of trouble at night. And what you can see here is that we've got a central hub, which is in the sort of central nightclub area. And then we'll see stabbings either side of that as well. And we can break it down even further down to real locality here. Very interestingly, the red blob to the left there, which is large, I was trying to work out what that is. That's actually a police station, and that's where people go when they report having been stabbed. And the area that you'll see that looks almost just below the S of Milton Keynes, that's what's known as the Snow Dome. There's a lot of nighttime economy there. You get a lot of youngsters hanging around there in the evenings, and we think that's probably why we're getting so many stabbings there. This is actually work that we do in collaboration with the police, and clearly if we identify areas, we do notify the police so that they can go and do some prevention work. But of course, if we find an area where we're likely to get stabbings, then that's where we can move our response teams who work on cars. So for example, moving them to the centre of a city during the night when we know that we're going to get incidents. And if we look at the demand profile, what you'll see here, and I think this is fairly interesting, I was asked whether stabbings were going up or not. So I basically worked with our violence reduction units, and what you'll see is that in November 16 we suddenly get an increase, and I've circled that with red. Now I was trying to work out what's happened here, but this is actually when we went fully live with electronic patient records. So what you'll see is that absolutely tallies with what I said earlier about November 16, and you'll see that there's an increase there. So we've probably got better reporting, but unfortunately what we are seeing is there's a growing picture, and you can see that unfortunately the trend is always upwards. We always get an increase in stabbings in summer months, so our summer when it gets hot, and usually there's a bit of a reduction throughout the winter. We can also look at, for example, the days of the week and the times when our stabbings are most likely to happen. You can really understand now the importance of this for our resourcing. And no great surprise is that a significant number of our incidents happen in the early hours of Saturday, so from Friday night through to Saturday, and also Saturday night into Sunday. And that's when we see disproportionate numbers of stabbings, and then they tend to tail off throughout the night and then remain fairly flat during the day and then increase again in the evenings. In terms of EPR, the potential is huge, obviously for health observation mapping. So what we can do is, of course, identify trends such as road traffic collisions, falls, etc. So we can use this for prevention. We can absolutely use it to use our resources appropriately, so the deployment of our resources. And there's no doubt at all that there will be an improvement in clinical care. We've obviously been using electronic patient records for research, and that will only benefit patients in the long run. And the other things we can do is, for example, to map epidemics and pandemics. So, for example, if we've got a flu pandemic, then we can look at that. We can look at areas of sepsis, and I have already done that piece of work. We can look at meningitis, and sadly, that's often universities, particularly in that sort of September, October time. And of course, COVID-19, the big C word, which unfortunately we have been particularly badly hit in the UK, although the South Central region hasn't been as bad as some other areas. But what we've been able to do is to actually map hotspots. This looks at wave one, which basically was around about April 2020, and you can see that we've got some significant hotspots. And you may say, well, why is that important? Well, for example, if we found we had high levels, then we would prime a whole load more PPE into those areas. So if we found that we did, as we did here, you can see Southampton in the south and also the Portsmouth area and parts of Milton Keynes as well, we're seeing very high levels of COVID. What that meant is that we could actually equip our staff much better. We also were able to do local information, so we could give staff better understanding of what they should do in terms of the conveyance and non-conveyance of patients with COVID-19. So this is looking at wave 2, and you'll see it is slightly different. We've got what we've described as the dumbbell of death in the south. I have no idea why, but we obviously saw a big increase in COVID around there in wave 2. So this is looking at sort of October 2020. But again, you can see pockets, and in fact, Reading was one of our hotspots that we saw. So fascinating work, and we were able to literally map that live time. So in summary, SCAS are using EPR data to improve patient care. The key for any ambulance service who are considering introducing electronic patient records is the training and the familiarity, allowing staff time to actually experiment, to play around with mock devices, etc., and to make sure that they've got adequate training. I certainly would advise that you use keyboards as well. That definitely brought down our on-scene times quite significantly. And as you can see, the output from EPR can be used to improve clinical care and reporting. We've really got some amazing reports, to the point where we've almost got so much data that we don't know what to do with it. And of course, it can be used to inform improvements in resourcing and in our deployment models. So for us, EPR has been really the best thing since sliced bread, and actually is really improving the care that our patients are now receiving in SCAS. I was going to ask about questions, but I think the guidance is that questions are going to come at the end. But again, I'd just like to say thank you very much for inviting me to your conference, and I hope that you all have a really good day.
Our second speaker today is Sam Allender. Sam is an experienced paramedic of over 16 years, with 8 years working in all levels of secondary triage with Ambulance Victoria. Sam's been involved in the review of ST and its expansion to now triaging approximately 30% of all 000 calls at Ambulance Victoria. In 2019, Sam took on the role of project manager for Ambulance Tasmania to manage the development and implementation of secondary triage that was launched earlier this year in February 2021. Welcome, Sam.
Hi everyone, I'm Samantha Allender. I am a paramedic and the project manager for secondary triage for Ambulance Tasmania. My presentation today is the connected patient. I am presenting from Hobart, and today I'd like to pay my respects to the traditional and original owners of the land on which I stand, the Mulwanina people. I pay my respects to elders past, present and emerging, and acknowledge today's Tasmanian Aboriginal community who are the custodians of this land. I also acknowledge any Aboriginal peoples in attendance today. This presentation will provide an overview of the way that Ambulance Tasmania has used data to reform patient assessment and the management of patient care and ambulance service delivery to connect patients to the care they need. It will include sharing the data that initiated the reform, the solutions that we've implemented, primarily secondary triage, and the strategic partnerships that have been developed to support alternate patient care, and how technological innovation can support greater patient safety in secondary triage. And I'll conclude with some learnings that we have taken from our journey. Internationally, there has been a recognition of an increase in the utilisation of ambulance services for conditions that would have previously been managed by other services within the health and community sectors. Ambulance Tasmania has seen an exponential growth in ambulance service demand, with approximately 22% growth in the past 9 years, growing 14 times faster than Tasmania's population. Without reform and the introduction of a strategy that allows for clinical assessment and prioritisation of a patient's presenting symptoms, the emergency-focused model of Ambulance Tasmania would have continued to direct patients towards emergency services that exceeded the needs of the patient, resulting in inefficient utilisation of health resources, with poor patient experience of the health system due to long wait times for both an ambulance and treatment in an emergency department. To connect patients to the healthcare they need, we need to rethink our place in the healthcare continuum. The call to 000 provides us with an opportunity to deliver, direct, and impact on patient care and experience. In Tasmania in 2020, almost 84,000 episodes of patient care were initiated by a call to 000. To ensure that patients receive the care they need, organisations are changing their thinking about the role of ambulance in healthcare provision. No longer thinking that ambulance provides a separate component to a healthcare episode. By taking a systems approach and looking through the lens that has ambulance care as part of the healthcare continuum, we can begin to understand where the challenges and opportunities lay that will ultimately impact on patient outcomes. Making connections and engaging with services to enable greater efficiencies and better patient experiences and outcomes. It has also been important to provide public awareness that there's been a change to the way ambulance service provision is delivered so that community expectations can be aligned with operational strategy. Secondary triage was the solution, and through the implementation we are striving to improve our service, informed by the best available data, and provide a focus for the development of referral pathways and partnerships. Secondary triage ensures that patients were connected with the services aligned to their healthcare needs when the dispatch of an emergency ambulance was not warranted and there was no need to attend the emergency department. Understanding the data and the options available to mitigate risks associated with this solution ensured that positive patient outcomes and experiences were continued. Strong strategic partnerships with key stakeholders were the key to ensuring that together we could provide access to services that help Tasmanians lead healthier lives and connect them. The Private Emergency Department initiative involved a collaborative relationship to assist with offload delays at the busy public emergency departments. It's a partnership arrangement negotiated by the Department of Health, Ambulance Tasmania, the Tasmanian Health Services, and the private hospital emergency departments. This mechanism is activated by the Ambulance Tasmania Executive when Surge Level 4 is declared. The hospital is contacted to request that ramped crews are released where this is not achievable. Ambulance crews currently en route with low and medium acuity patients are notified by the in-vehicle information system and directed to private emergency departments for assessment and treatment that are paid by the hospital. This arrangement has assisted with offload delays, provision of better patient experience, and ensures that operational resources are available for dispatch to incoming cases. Another pathway, funded through an election commitment by the government, is an arrangement that has been negotiated by the Department of Health, Ambulance Tasmania, and an urgent care centre in Launceston. In this case, the $150 facility fee is covered by the state government for eligible concession card holders for medium and low acuity cases that would need to present to the emergency department if this was not an option of care for them. A further rollout of this initiative is likely throughout the state over the next 12 months. The development of additional referral pathways from secondary triage to support the community have also been initiated by data analysis. For example, when recently reviewing demographic data of the patient cohort that has been assessed through secondary triage, approximately 5.17% have identified as being Aboriginal and/or Torres Strait Islander descent. This is slightly higher than represented in the 2016 census, where 4.6% of the population identified as Aboriginal and/or Torres Strait Islander. Although a partnership already exists with an Aboriginal health service in the northwest, this data highlights that further opportunities exist for development with services in the north and the south that will support this vulnerable population to engage with services that can impact positively on their health outcomes. A key patient safety risk with telephone triage is the inability to see the patient and gather the visual cues that often support good clinical assessment, and not being able to assess vital signs that paramedics have traditionally utilised to inform patient treatment and management. The advancement of technology and utilisation of artificial intelligence and machine learning in the healthcare sector will soon begin to support patient safety with innovations that assist to replicate the areas that have not been available with traditional telephone triage. Two such innovations that Ambulance Tasmania are currently investigating are video conferencing and respiratory assessment. The video conferencing that we are investigating involves the GoodSAM platform, which offers video conferencing that will allow the clinician to send a message to the patient, and when that is opened, it will open the phone's camera and begin streaming to the clinician. Through AI, this technology offers an ability to have vital signs such as heart rate and respiratory rate analysed, providing additional clinical data for the patient assessment. Preliminary results indicate the utilisation of video conferencing and the added situational awareness has impacted dispatch decisions in approximately half of the calls where this technology has been used, both to upgrade cases and also to downgrade for diversion. ResBap is an application originally developed at the University of Queensland that uses breath and cough sound analysis to provide information regarding the patient's respiratory tract health or illness. Taking a machine learning approach to construct algorithms based on sound recordings with known clinical diagnoses, the machine learning tool finds the optimum combination to create an accurate diagnostic test or severity measure. Having this information available will provide the clinician with additional information that may improve patient safety, treatment, and management. By rethinking emergency healthcare, reforming the ambulance service delivery model and building strong partnerships, Ambulance Tasmania is creating a more efficient system, getting our paramedics to the people that need them most, and connecting others with services more aligned with their health or social care needs. Our key learnings have been that our data has provided insight for developing strategy and innovations that can be leveraged to ensure efficiencies within the healthcare system. Understanding that healthcare provision begins with a call to 000 and that ambulance services have a key opportunity to direct patient care in the appropriate direction at the time of 000 call is fundamental to all things that come after. Strong strategic partnerships promote connectivity for individual patients, but it also ensures understanding of other organisations that ambulance service provision is an essential part of a patient's health continuum. Technological improvement will continue to emerge and develop, and this will assist in supporting patient, clinician, and organisational safety, particularly in the field of telephone triage. If you have any questions, please use the live chat box and I will hopefully be able to cover them in the live chat.
Our final speaker today is James Wetherall from Trapeze Group. James is a proven leader delivering sustainable business partnerships across mission-critical and information-intensive industries. With extensive experience in software project implementation and management, James leads the Trapeze Emergency Services team, who share his passion and enthusiasm for implementing and operating innovative solutions in the public safety space. Welcome, James.
So thanks, David. So hello everyone, and thanks for taking the time to join today's webinar. It's been fantastic to work once again with the CAA to bring learnings and insights from the industry. We're also grateful to our special guests, presenters today. So Sam for sharing how one of our customers, Ambulance Tasmania, are developing alternative treatment pathways for the Tasmanian public. And for Mark for getting up so early and sharing the great insights and action plans that South Central Ambulance, supported by one of our strategic partners, are achieving to deliver an integrated patient and health service experience. Both those examples are showcasing the value in understanding your operations, your customers or patients, and the operating environment. So today I'm going to talk about some possibilities for the future of integrated patient care information and discuss how we can leverage learnings and strategies from other industries which are being used to drive integrated information sharing. We'll also look at the correlations with connecting clinicians and data to support patient outcomes and deliver truly integrated collaborative patient care. So we're seeing the compounding effects of data all around us. How is it that with so much information available, and Mark even alluded to this in his talk, we still feel like we don't have enough information? The ability to capture and understand, let alone comprehend what's being generated, can be overwhelming. This can be attributed to a multitude of scenarios, including the proliferation of standalone point solutions. We've seen this happen a lot during the C word, as Mark puts it, and often delivered through so-called necessity. We'll worry about the integration later. And stretched resources where we need a solution now. We're waiting for Project X, so we'll just do something for the minute and we'll deal with it later. Proprietary data silos which actively prevent information sharing, and allowing information to be captured on paper, never again to see the light of day. So what does this mean for delivering integrated patient care, where there is no single view of the truth? Providing a consistent experience is a pipe dream, and analysing what should happen, what actually happened, and what you want to happen in the future, it's extremely difficult. Does it need to be this way? And can we look at other industries to see how they are solving similar life cycle problems? So I promised before I sent this video there was a bit of an animation. So I'll probably post that on LinkedIn later. So we see similarities with building information modeling, or BIM if anyone's been exposed to that. So this allows organisations to collaborate across the entire life cycle of infrastructure, from concept development to planning, the actual construction, and then all the way through the operation to its disposal. But it goes much further than a 3D model. You're able to do things like run evacuation scenarios, develop costing models, and model human behaviour and how they might interact with that infrastructure. Things like, do we have enough space and facilities, and will people utilise it? Even think about how this relates to emergency response. How would you gain access to floor 3 from the basement car park? Can the industry collaborate with others? So this approach is a journey and requires a mindset change. We need to think about maturing into this state. So this starts from level 0, where digital information is produced and shared, but it's typically operating in silos with no coordination. Think about an Excel spreadsheet which contains all your rostering information. To something like a level 1, where you're operating in some common type of environment to collect and share information. But this is probably focused on single projects or scenarios. And we typically see this in things like finance systems, and typically of older style EPCR solutions, all the way to something like a level 3 full integration, where you're working on a fully interoperable environment. You have a single view of the truth, and where cause and effect are modelled and visualised in real time. What could we call something like this? So to use another term, terms such as big data and analytics, data science, data ingestion are all hot topics, but they're really looking to solve one problem: to represent the physical world in a digital environment. To talk about this in more general terms, one of the key enablers for a connected journey is the concept we'd like to talk about of a digital twin. So a digital twin, from this lovely drawing, is a virtual representation that serves as the real-time digital counterpart of a physical object. This basically is some data model that's mirroring real life. It's fundamentally open and interoperable, and then you can leverage it to share in real time with all stakeholders. It exists in perpetuity and is added to, modified, and interacted with by all stakeholders. So what could this mean in the context of an integrated patient care records, where all parties have the same single view of truth? There are no data silos, and the information is shared in real time. We can then understand how things are related historically, as incidents are unfolding in real time, or even projected into the future. So at level 3, a level 3 EPCR solution would facilitate this. This is next gen and enabled through digital twins, where it's the holy grail. There are no data silos, and you can participate on any device as the situation unfolds. So some people might have seen these before. So imagine the scenario, taking a simple process flow. At level 3, you're allowing full visibility of the patient journey. So if we look at something like the model builds from a call being received to being dispatched, where you're being updated on the incident location and any access requirements. Think back to the access level 3 in the basement. The patient's medical history has been retrieved, and the paramedics en route are alerted to particular care requirements. To arriving on the scene where you are evaluating the incident, the dispatch centre is receiving real-time updates, and the ED has been alerted. It's definitely some of the stuff that Sam's looking at, and Mark also talked about this real-time into the ED. This patient's GP has also been alerted and provide commentary to the team on pre-existing conditions of the patient. The patient is to be transported to a major hospital 60 minutes away, and the crew will be handing over the patient midway. The transporting crew already have access to the patient information and are making plans with the receiving emergency department. The crew transfers the patient to the next vehicle seamlessly, and there's no paperwork required. The ambulance crew is received into Bay 3. As easy as this, they've completed their intake procedures en route to the hospital, and they've been talking the whole way. To really the handover at the ER, where the patient is taken directly from the ambulance for treatment. So this is obviously a really simplified story, but where we're looking to build that digital twin model through the patient journey, it allows this kind of information sharing. There are endless possibilities when we're talking about a fully integrated level 3 environment, and it's possible today. But that's probably just the start. So moving to something like a digital twin mindset allows for things like just kind of everyday scenarios like management of restricted medication, where we can do things like real-time authorization and approval requests at the point of care, which can then be fully audited and analyzed for the future. We can definitely produce some more data for Mark to worry about. To things like information sharing, where you can solve massive problems like incorporating demographic information, a platform to integrate into national health records, and share information with other health services around like HL7 data. while maintaining your control over your own domain. And things like knowledge protection with aging workforces, in aging workforces and young workforces, removing it being acceptable to build tacit knowledge, and make it a no-brainer to contribute to the collective knowledge base, get rid of the paper. And things like real-time, real-life simulations, providing staff with real-life learning opportunities. Think about things like augmented reality to replay what happened. There's a lot of work being done in this space around sensors and to pull a lot of data in. What would this enable your organization to do? To my animation at the end, so imagine that spinning. So moving towards a level 3 full integration is a natural progression. Continuing to do the same will likely yield the same results. Setting our sights on the future of EPCR is a great start and truly puts the patient at the center of everything we do. Developing this out will take some time, but you've heard today from Mark and Sam about their own organization's journeys. You need to start somewhere, and there is no better time today. And why not do it with a cool acronym like digital twins? Thank you, and I'm going to hand back to David, and I'm really keen to hear questions from the audience.
Thanks, James. We'll just wait for our other presenters to jump back on stage. So firstly, thanks to our three guest speakers today. Mark, thanks for getting up so early. Appreciate it. Sam zooming in from Tasmania, and James from the Gold Coast. Firstly, can I just say, I realise now I should have used the matrix digital waterfall background for my presentation, because we are certainly looking into the future here. It's really exciting. So I've got a question for you, Mark, first up from Anthony. With your data that is of interest to the police, e.g. stabbings, is this integrated with their system so they can access it at a time, in real time, help with planning of their resources as well?
No, it's done retrospectively. So we'll analyze the data, and then if we find hotspots, clearly that's an area where we could probably improve. But we do work in partnership with the VRUs, the violence reduction units, highlighting any areas that we've got concerns, but it's not live time, and perhaps that's something we should work for.
Thanks, Mark. I have a question for you. Thanks for your presentation. I found it really interesting to see how far the traditional electronic patient care record is really evolving. If you had a crystal ball, what does EPCR 2.0 look like in the next few years?
So I think we have to think, first of all, where we've come from. So in 2016 to now, 5 years, we've advanced hugely. So already we've done some massive changes, and that's obviously the way we've adapted our system, so the reporting, etc. So actually, I think we're already on version 2.0 because of the natural evolution that's happened. But I think there are some improvements that we could still make. I think as you increase the data fields, that can become more complex for clinicians out there. So somehow I think we need to narrow that data set down. I know arguably that will reduce the quality of information, but actually there's so much information on there that sometimes that can, delay your on-scene times. And the worst thing you want to do is to have other as a field on your electronic patient records. As soon as you put that in there, so I absolutely get the need for having lots of fields, but somehow we need to just condense that and make it better. But I'd argue we're already on 2.0 simply because of the natural evolution through it. In terms of other improvements, linking, for example, the crew directly with the control room would be useful. We can do that via the phone. We do that already, but perhaps a live link, and we're already starting to do that now. So our air ambulance teams can then view as well.
And it's got kind of a nice segue into a question I've got for James, actually, is that, in our current environment, we're really reliant on digital data entry into our electronic patient care records. What do you see the future being to kind of, speed up that process and keep the paramedics hands-free for care of the patient rather than as a digital input device?
So I'll probably make it up as I go, David, but
that's good.
There's a lot of work being done in like voice detection. We've seen a lot of studies and done some work ourselves on like noise isolation in the front of an ambulance with sirens and How do you pull key bits of information out? I don't think we're going to get away from, like, even what Mark was saying. That was pretty funny. It's like the biggest step change was a keyboard. I thought that was fantastic. But I also see, like, particularly in the sensor space, like where you don't actually have to capture information, it's like getting captured live. So we're seeing things like the point clouds and LiDAR, like where you can start seeing taking scans of the back of an ambulance or in the ED, and it'll identify people, things, features, then you won't have to manually do it. Something in like just the getting better at collecting data, and we won't get away from manually typing.
Sure, not just yet.
Not just yet.
No. Sam, I've got a question from another David, I think in New Zealand. Sam, did you identify any age groups where video conferencing was less successful, so technology related? And if so, were you able to put in place a workaround?
We actually haven't trialed any of the data. That the statistic that I provided was from other sources that when they've used that technology. We're sort of just in that exploration phase at the moment. But having a look at the Tasmanian demographic, obviously we do have an ageing population that's not necessarily digitally connected. So we'll definitely be having strategies to develop to sort of enhance that and sort of work around that situation.
Mark, I think this is a question for you. It's from Steve. Can you give us an idea of how much work is required to mine the data that you're using and to turn it into the quality of presentations that you're able to show us today, and able to use, obviously, to show your superiors in order to affect change?
Yeah, so we're really fortunate to have a quite fantastic business intelligence team based within our organisation. And business intelligence has always been around performance and times and on-scene times and everything else. But the new assistant director is very positive that the information should be used for clinical reasons. So I've got a data analyst that is who works through the data. All of the information is stored securely, but then she can access it, and then basically she can change. So if we want to look at COVID or anything like that, then we can do that very easily. We do work with other partnership agencies. So, for example, there's a piece of work going on at the moment with Ordnance Survey, which is a national. They do mapping generally, that type of thing, but they can literally map on our road accident maps, the side of the road and whether there were lampposts involved and all this amazing stuff that they can do. And they do that for free because there's a contract for them to do some sort of, it's almost like charity work as part of their contract. So we do work with other agencies, but of course we'd never give any patient information out. In fact, we actually break the postcode down for where the patient lives by deleting the last 2 digits so that there's never any identifiers in any way.
Perfect. And that's a great segue into my next question. I've got a number of questions in the chat really around patient confidentiality and managing that in this new digital environment. And I think our attendees are really keen to understand kind of any challenges you've had in maintaining patient confidentiality. Well, I'll start both with Mark and Sam because I think it's relevant in both situations.
So from a consent issue, we always consent from the patient. And one of the questions we tick on the electronic patient records is whether that patient is happy for their data to be shared. Clearly, we don't share it with everyone. It's secure and it goes to any transfers go via an nhs.net account. So it's not going over some email or Gmail. There is a move at the moment, actually, where sometimes we could potentially email the patient their own notes. And that's a piece of work perhaps that we need to think about improving, but that's really good, then they can keep a summary on their phone. There's nothing wrong with that as long as it's done via a secure link. But currently the way our information is transferred is to secure links straight to, for example, the GP, the receiving hospital, etc.
Thanks, Mark. And does that also apply to getting access to patients' previous data from other medical professionals?
Yeah, that's correct. There's a summary care record which we have access to. So, for example, a patient with mental health, you can't just access that. You have to have an NHS identity card, which is inserted into the device and allows you access. And we always consent the patient to access that data. If they said no, then we wouldn't. And actually, there is behind the scenes a record to see who's accessed any records, so that if we ever need that for audit process, it means we could make people accountable for accessing that information. So I like to think it's a really secure way, and we get a printout every month of the people that have accessed information, so that they can be chased up.
Thanks, Mark. And Sam, from your perspective in Ambulance Tasmania?
Given that Ambulance Tasmania is under the Department of Health, so we're under that umbrella, we've got agreements with the Tasmania Health Service to access the digital records of patients that are coming through and into the hospital systems here in Tasmania. And that's been very much a collaborative approach, understanding that ambulance service is now part of that healthcare journey and provision. So trying to make that a seamless journey and have all clinicians have access to that. And like Mark alluded to, there is transparency behind any access of that data, with all clinicians accessing that data requiring a log on to get that.
Thanks, Sam. I'm just aware of the time. I think we've got time to squeeze in a few more questions because our audience is still here, so we can keep pushing on. I've got a really interesting question for you, Sam. And it's kind of twofold. Really interested in how you've been able to manage patient expectations in relation to them not receiving an ambulance, but getting or potentially going to get some kind of digital event. And how has the community responded to this concept of secondary triage?
One of my key learnings that I sort of brought from Victoria and listening to and reading about the experience of South Australia was an understanding that consumer awareness was really going to play a factor in how receptive they were to the change in the ambulance service provision. And with that in mind, I was very comfortable to promote a public awareness campaign for the introduction of secondary triage. So that coincided with the commencement of secondary triage in February, and it included some television commercials, some social media, some print media and radio interviews. And that was predominantly just to get the message out there that in some instances now, when you call an ambulance, it won't automatically be the response of an ambulance attending anymore. It will be a nurse or a paramedic that will have a discussion with you and make an assessment and work out if that's what you actually need today. And so far, it's been very well received. We've been able to link patients with the care that they need, and some of those care pathways that we have in place are providing that those patients with ongoing support through the services that they are being able to be linked with, like continence care. So a Tasmanian Lifeline, which is a low acuity mental health and support line. So patients is continually being able to access that support that has been initiated by secondary triage, which is great.
Thanks, Sam. Well, I think the future is really exciting in this space, lots of innovation. Sam, you referred to artificial intelligence a couple of times in your presentation. Mark, a question for you. Where does artificial intelligence start meeting the electronic patient care record in your service?
Do you know what? I really don't have the expertise to answer that. But clearly we can improve things. We are already, obviously, the NHS is under extreme pressure at the moment. I'm sure everyone will be aware it's not all COVID related. It's exactly the issues that Sam was talking about. So we are already having to use other ways of working to decide who does and doesn't get an ambulance. So it's already sort of being rationed. Clearly everybody does get an assessment by an ambulance, but perhaps there are ways that we can improve that part of it, particularly for the patient.
I think it's around like what's repeatable and what's not, and looking for patterns. I think it's like identifying some of those use cases. I know Tasmania have done some of that, and Victoria are heavily invested, and Singapore's heavily invested. It's rapidly evolving.
And James, if you can wave your trapeze magic wand, what's the future looking like? What can we expect to see?
You don't ask small questions, David Waters. I think it's just I'd love to see the discussion move on from collecting data and business intelligence. Like, it's very people heavy, and like actually, help with knowledge. Like, we shouldn't have to focus so much on that. It's kind of, we collect it. We maybe have some AI, some artificial intelligence sifting through it, and it's like, Mark or Sam, like, here's something important you should know. Kind of just take the heavy lifting out of it as people. I think that's definitely where I'd see the future. How soon that is, I don't really know, but it's like it shouldn't be this hard to get the insights.
Yeah, and that's really a nice point to kind of round off the conversation on. I think all our services are tracking towards a digital future. It's really exciting. Technology can really enable the paramedic and ambulance workforce to work and be really effective. So we look forward to that. And we'll continue to have these conversations about what the connected patient and connected data and connected care is going to look like in the future. So I really appreciate your conversations today, your discussions and your presentations. It's been really insightful, exciting times ahead. So special thanks, Mark, for you getting up so early. That's great. Thanks, Sam, for joining us today and sharing your learnings around secondary triage. James, thanks again, and a special thanks to Trapeze for making this happen. This is a really important conversation, and we're keen to keep it going. Thank you for facilitating that. To all our viewers, thanks for attending. I hope you've enjoyed the session and got something from it. Again, thank you all for joining the CAA 2021 webinar series. Take care out there, and we hope to see you soon on our next webinar.
Thank you for attending the Connecting Clinicians and Data to Influence Patient Outcomes webinar, proudly supported by Trapeze. Join us for our next webinar on Thursday, the 21st of October at 3 p.m. for Mastering Operation of Mechanical Chest Compression during CPR, presented by Professor Lars Wick and proudly supported by Stryker. In the meantime, be sure to follow us on social media, Twitter at the Council of AM1 and Facebook and LinkedIn, the Council of Ambulance Authorities Australasia. Thanks so much for joining us, and we'll see you next time.